Nephrology. Adult medicine nephrology. 1 UTI 2. Electrolyte imbalances 3. Glomerulonephritis 4. Urinary incontinence 5. AKI 6. CKD 7. Emergencies. Urinary tract infection. Quick summary. Signs, symptoms, physical exam. Asymptomatic bacteriuria. None. Acute cystitis. Fever, flank pain. Acute pyelonephritis. Plus, fever, plus/NNV, plus, flank pain, plus, CVA tenderness. Complicated UTI. Male 12, 50 yo pregnancy H-, plus, indwelling catheter. Diagnostics. Gold STD, microscopy, CNS of MSU. Plus, MSU culture 10-8 Kfu/L. Acute cystitis. Plus/microscopic hematuria. Acute pyelonephritis. Culture. Management. Asymptomatic bacteriuria. None except, pregnant treat X 5 days 1. Cephalexin 2. Nitrofurantoin 3 coamox. Repeat. Acute cystitis. 1 TMP 300 mg ODX3D2. Cephalexin 500 mg Q12X5D3. Nitrofurantoin. Acute pyelonephritis. Mild, X 14 days coamox 625 Q12 cephalexin 500 mg QID TMP 300 mg OD. Severe, admit 4x2-5 diamox 2G/4 plus genta 4-6 mkd oral X14D. Complicated UTI. 1 trimethoprim 300 mg ODHSX3D2. Cephalexin 500 mg Q12X5D. Asymptomatic bacteriuria. A definition and causes transient, poor collection. B. Clinical features. None. Usually, an incidental finding. Diagnosis, plus, MSU culture 10-8 Kfu/L. Management. None except if pregnant, urolithiasis, VUR, renal transplant recipients, the immunocompromised, and before instrumentation of the urinary tract. Pregnant, empirical first-line antibiotic therapy ephelexin 500 mg Q12 for 7 days, nitrofurantoin 100 mg Q12 for 7 days, coamoxiclop 625 mg Q12 for 7 days. Repeat MCU at least 48 HRS after completion. Repeat sample collection, may be due to poor collection. Acute cystitis. A definition and causes acute inflammation of the bladder usually associated with bacteriuria, bacteria in the urine, and pyuria, presence of white cells in the urine, but both can occur without infection. Bacteriuria may be due to either colonization or infection of the urinary tract, or contamination of the collected urine specimen. Non-infective cystitis may be caused by urothelial carcinoma, bladder calculi, chemicals, or interstitial cystitis. B. Clinical features: dysuria or pain after micturition, frequency, urgency, cloudy or offensive urine and discomfort or pain in the bladder, urethra, or vagina. C. Diagnosis: history and symptoms are adequate. D. Management: non-pregnant, empirical first-line antibiotic therapy Rimethoprim 300 mg, O, for 3 days or cephalexin 500 mg Q12 for 5 days, nitrofurantoin 100 mg Q12 for 5 days, 10 days if, plus, urinary tract abnormality. Pregnant, empirical first-line antibiotic therapy Eflexin 500 mg Q12 for 5 days, nitrofurantoin 100 mg Q12 for 5 days, coamoxiclav 625 mg Q12 for 5 days, repeat MCU at least 48 HRS after completion. Adult male, TMP 300 mg, O, daily for 7 days, cephalexin 500 mg Q12 for 7 days, coamoxiclav 625 mg Q12 for 7 days, nitrofurantoin 100 mg Q12 for 7 days. Other first-line choices: amoxicillin with clavulanate, plain amoxicillin, if the organism is susceptible, nitrofurantoin. Acute pyelonephritis: a definition and causes infection of the renal parenchyma and pelvic calyceal system as result of bacterial ascent along the ureters from the bladder to the kidneys. Can progress to septic shock, renal failure / multi-organ failure. MCC organisms: Escherichia coli 80%, Klebsiella species, Proteus species, Enterbacter species, Pseudomonas species. Clinical features, plus, loin pain, plus, constitutional symptoms, fever, rigors, nausea, vomiting plus or minus cystitis symptoms. Rule out causes of acute abdomen, appendicitis, cholecystitis, acute tubal or ovarian diseases. C. Diagnosis: MSU, plus, leukocyte plus, nitrite, urine microscopy, plus, WCC greater than 10x106 and bacterial colony count greater than 106, single organism. D. Management: analgesics for pain. Admit if patient is unstable, respirations 10 or greater than 25 per minute, SpO2 95%, systolic blood pressure 100 mmHg, pulse 50 or greater than 120 per minute, altered LOC or change in cognitive status, temperature 35.50 C or 38.50 C. Mild infection: coamoxiclav 875 plus 125 Q12 for 14 days, cephalexin 500 mg QID for 14 days, TMP 300 mg, O, daily for 14 days, norfloxacin 400 mg BID for 7 days, ciprofloxacin 500 mg BID for 7 days. Severe infection: admit 4 antibiotics for 2 to 5 days, amoxicillin 2G/4Q6 plus gentamicin 4-6 mkd, O, 4 followed by oral UB for a total of 14 days. Complicated UTI: definition and causes. B. Clinical features. C. Diagnosis. D. Management: empirical first-line antibiotic therapy Rimethoprim 300 mg orally at night for 3 days or cephalexin 500 mg orally twice daily for 5 days. Their first-line choices: amoxicillin with clavulanate, plain amoxicillin, if the organism is susceptible, nitrofurantoin. Second-line therapy: quinolones, ESP, if resistance has been documented or in the presence of P. aeruginosa. Recurrent UTI. Definition and causes: acute onset of dysuria and frequency in a young woman in the absence of concomitant vaginal irritation or vaginal discharge gives a 90% probability of UTI. B. Clinical features. PE, look for anatomical or functional abnormalities of the urinary tract including atrophic vaginal change and pelvic organ prolapse. C. Diagnosis, $% and $, comma and /0 and 1 and 2 3, 1/0 456, 7, $8% and $, comma and D. Management. Pharmacologic. Non-pharmacologic. Vaginal estrogen. Ostmenopausal women, protects against colonization by uropathogens via an increase in protective vaginal lactobacilli. Methenamine hippurate as a bacteriostatic effect in the urine. Recommended dosage is 1 g twice daily, but studies have not defined optimal duration. Cranberry products potentially decrease the frequency of symptomatic UTIs. 150 ml cranberry juice bid 1 tablet bid. D-mannose ought to have an antibacterial activity by inhibiting the adherence of bacteria to urothelial cells. Imited randomized prophylaxis trials. Probiotics, Lactobacillus species, no convincing benefit. Prevention. Increase fluid intake. Proper sexual practices. Postcoital voiding. Contraceptive use. Electrolyte imbalance. I. Potassium. A. Hypokalemia. I. Definition. A. Serum K 3.6 milliequivalent/L. B. MCC, abnormal losses. Diuretics, common cause of renally mediated hypokalemia. Chlorthalidone HCTZ $8 and $1/ and $880 0% A, $3 and B0. Diuretics, common cause of renally mediated hypokalemia. Chlorthalidone HCTZ $8 and $1/ and $880 $8 and $1/ and $880. Insufficient intake. Rare cause but contributes to hypokalemia in hospitalized patients. Assessment. Identify warning signs, urgent treatment, signs and symptoms, weakness, palpitations, ECG changes, K 2.5 milliequivalent/L, rapid onset hypokalemia, underlying heart disease, cirrhosis. Rule out causes of transcellular shifts. Identify hypomagnesemia. Def. and 3% $G $8% def. and 3% $G $8% Initial workup. Serum KFBG, mg, UNEC, ABG24HR. Urine potassium. TFTs. Adrenal function. ECG. Early, decreased T-wave amplitude. Late, ST-int depression, T-wave inversion, prolonged PR-int, U-waves. Arrhythmias, sinus bradycardia, VTach, VFib, TORS. Aids to points. Management. Increase serum K4 K20 to 40 mol plus 1 LNS. Evera hypokalemia, plus, ECG changes, symptomatic, unable to tolerate oral K. SE, hyperkalemia. Oral potassium 40 to 100 mol/D. Plus, history of CHF or MI, goal equals 4 mol/L. WOF, rebound hyperkalemia. Correct hypomagnesemia cease or decrease loop diuretics. F drugs that may increase K, ACEI/ARBs, beta blockers, K-sparing diuretic. B. Hyperkalemia. I. Definition. A. Serum K5 mol/Lb severe, greater than 5.6 mol/Lc causes, usually multifactorial cause, most common impaired renal function, derangements in I. Rate of flow in the distal nephron, CHF, cirrhosis, AKI, CKF. 2D, $8, $1 KL60 at percent, $8 and $1 and C0 at percent, $8, 1 and 3 m. Potassium secretory pathways medication. I2. N8 if/0/ DG $2 C $8 and 1 GI percent medication. I2. N8 if/0/ DG $2 C $8 and 1 hyperglycemia. Assessment. A. History. B. Physical exam. Identify warning signs, urgent treatment needed, symptoms. Muscle weakness, ascending paralysis, palpitations, paresthesias, generalized weakness, decreased DTR, ECG changes, severe hyperkalemia, rapid onset, underlying heart disease, cirrhosis, kidney disease. See ECG early, peak T waves, T wave flattening, prolonged PR interval, wide QRS complex, sine waves, arrhythmias, sinus bradycardia, sinus arrest, VTach, VFib, azystole. 3. Management. A4CA cardioprotection. No effect on plasma K levels. Duration, 30-60 minutes. B. Insulin plus glucose. Most reliable method. Insulin 10U plus 25G glucose, prevent hypoglycemia, SE, hypoglycemia. C. Inhaled beta agonist adjuvant for shifting K intracellularly, not to be used as monotherapy. D. Dialysis. Kidney failure or life-threatening hyperkalemia or failure of other strategies. Sodium. Hyponatremia. Definition. Serum Na 135 mol/L. FAN, a marker of underlying disease. Severe, serum Na 120 mol/L. Associated with increased morbidity and mortality, especially in patients in intensive care, patients with hepatic cirrhosis, congestive heart failure and community-acquired pneumonia. Classifications, based on time of development. Classifications, based on fluid volume status of the patient. PIQ $3 and CKRs H6// V at percent, Q $3 and CKRs D6// J, at T, D, V at percent $8 Q $3 and CKRs HH6/. Assessment. History. Gastrointestinal or renal disease to suggest excessive solute loss. History of excessive fluid intake to suggest exercise-associated medication. History. Signs and symptoms: nausea or headache, development of lethargy, confusion, coma, or seizures. Diagnostics: renal function tests, creatinine, bun electrolytes, serum and urine osmolality, urine sodium. Management: euvolemic asymptomatic, initial, fluid restriction symptomatic. Hypertonic saline in serum Na 120 mol/L. Infuse 100 ml 3% Na over 1 hr. If persistent, add 200 ml over the next 2 hrs. Goal: raise the serum sodium into a safe range, 120 mol/L, and to abolish the patient's symptoms. Once goal is achieved, stop hypertonic solution, continue fluid restriction until improvement. Check serum Na every 2 hrs. Goal: Inc. serum Na, 6 to 8 mol/L. Max rate of Inc. of serum Na, 10 mol/L in 24 hours, 18 mol/L in 48 hours to minimize risk of osmotic demyelination/CPM. C/I, isotonic saline. Hypovolemic volume expansion, isotonic saline solution. Hypervolemic: treat the underlying cause, fluid restriction, diuretics. Prognosis: cerebral demyelination, irreversible and frequently fatal, D/T. Rapid restoration of serum sodium. B. Hypernatremia: I. Serum sodium levels greater than 145 milliequivalent/L. 2. Caused by A. Net water loss, increased loss or decreased intake, B. Sodium gain. Three. Risk for hypernatremia: A. Impaired thirst mechanism or restricted access to water. B. Altered mental status, intubated, infants, older adults. 4. Symptoms: A. Mild, anorexia, muscle weakness, restlessness, nausea, vomiting. $Q$8K, CI. $Q$8. V. Management: A. Correct the underlying cause. B. Correct free water deficit. Oral or enteral free water should be used whenever possible for fluids, hypotonic solutions. Rapid correction, cerebral edema. C. Target Na level, 145 milliequivalent/L. Glomerulonephritis. Proteinuria. A. Investigations: BP urine protein normal, 100 mg/24H. A. Abnormal, 300 mg/24H. B. Serious underlying problem, 1 g/24H. Glomerular origin, proteinuria plus dysmorphic hematuria/RBC. Cast dipstick test, 300 mg/24H. Proteinuria 150-300 mg/24H. Microalbuminuria 300 mg/24H, moderately increased albuminuria, macroalbuminuria 300 mg/24H, severely increased albuminuria. B. Nephrotic syndrome. Heavy proteinuria, 3.5 g/24 hours, disturbance of GBM. Hypoalbuminemia. Renal losses. Edema. C causes: low serum albumin, low plasma oncotic pressure. Minimal change disease, more common in pediatric population. Sudden onset of full nephrotic syndrome, adult, association with Hodgkin disease, chronic NSAID use. Pedia, association with allergies or viral infections. Focal segmental glomerulosclerosis OST commonly occurs in children and young adults. Present with the abrupt onset of the nephrotic syndrome, which may be severe. Management: high-dose immunosuppressive therapy. If no response, may progress to end-stage renal disease. Membranoproliferative glomerulonephritis MCC in elderly, 60-year, due to deposition of immune complexes in glomerular subepithelial space. Initial presentation, gradual peripheral edema. Management, if with heavy proteinuria, corticosteroids. DM nephropathy. D management refer to renal physician bed rest diet, low fluid, high protein, low salt. Pharmacologic, diuretics, prednisolone, phenoxymetyl penicillin, aspirin. Hematuria. Nephritic syndrome. Hematuria plus elevated BP. Causes: post-streptococcal glomerulonephritis, common GN among children, especially in ATSI, presents 7 to 10 days after GABS, throat infection or impetigo. Clinical manifestations: irritable, lethargic hematuria, co-urine edema, periorbital, scrotum, leg, rapid weight gain, oliguria 2 days, hypertension 2-4 days. Diagnosis: triad, discolored urine plus periorbital edema plus oliguria. GABS, antigenuria, electrolytes, ASO titer, antidinase B, C3. Management: admit, bed rest, fluid monitoring, daily weight, penicillin, if GABS plus, fluid restriction, low protein, high carbohydrate, low salt diet, antihypertensive, diuretics as necessary. IgA nephropathy MC, primary GN, adolescents and adults 50 YRS. Clinical manifestations: nephritic macroscopic hematuria within 1 to 2 days of mucosal infection, URTI, influenza. Diagnosis: triad, edema plus hypertension plus hematuria. Biopsy, plus, deposition of IgA antibody complex in glomeruli. Management: supportive treatment, ACEI/ARBs, corticosteroids. Good prognosis predictors of poor outcome: I heavy proteinuria, 1g/24 hours. 2 abnormal renal function. 3 hypertension. 4 interstitial scarring. Henoch-Schönlein purpura. C pediatrics. Systemic lupus erythematosus. C rheumatology. Bladder cancer, transitional cell carcinoma 90%, squamous cell Ca, adenocarcinoma. Smoking, MC association. DDX, hemorrhagic cystitis. Symptoms: hematuria, microscopic, irritative symptoms, frequency, urgency, nocturia, dysuria. Diagnosis: urine cytology, 3 specimens, cystoscopy and biopsy, imaging of upper urinary tract. Intravenous urography, IVU, 2. Ultrasound. 3. CT IVU gold standard. Management: smoking cessation. Treatment depends on grade, stage. Carcinoma in situ, intravesical BCG, intravesical cytotoxic, mitomycin C. Surgical. Investigations: renal ultrasound, non-invasive, no requirement for radiological contrast, that can be nephrotoxic, detecting urological abnormalities, renal cell carcinoma, etc., renal size, small kidneys, disease is long-standing, may not be reversible, parenchymal disease, GN, echogenic cortex, non-specific. Urinalysis: renal function, urea and electrolytes, GFR. TPAG. When to refer to nephro, a rapidly declining renal function, e.g. 15% decrease in GFR, b. significant proteinuria, greater than 1 g/day, c. glomerular hematuria and renal impairment, d. glomerular hematuria and proteinuria. Macroscopic glomerular hematuria. Urinary incontinence I types. Management. Exclude UTI and drugs. Stress incontinence, weak pelvic floor, Kegel exercises, obesity, weight reduction, menopause, HRT/vaginal estrogen creams, chronic cough, chest physiotherapy, genuine stress incontinence, GSI, plus urodynamic studies, pelvic floor muscle training, consider surgery. Urge incontinence, plus, neurological defects, refer abnormal voiding pattern, bladder retraining. Voiding dysfunction, plus, neurological defects, refer gynecological, refer bladder atony, anticholinergic drugs, intravesical treatment, oxybutyn and botulinum toxin. Catheterization. Drugs, anticholinergics/antispasmodics, sulfasalazine, propanthyline, oxybutynin. Tolterodine, imipramine. F. Pelvic floor muscle training, mainstay of treatment for GSI, 75% improved and 25% cured. Acute kidney injury. Forerunner of CKF, sudden decrease in kidney function, azotemia, with or without oliguria, fluid and electrolyte imbalance, accumulation of nitrogenous waste products, ink, bun, crea. Triad. Extreme malaise plus A/N/V plus confusion plus oliguria, classified as prerenal, acute circulatory failure - renal hypoperfusion, post-renal, obstruction renal, acute glomerulonephritis. Chronic kidney disease, severe reduction in nephron mass over time, uremia, MCC of ESKF, diabetes, MCC of nephritis, IgA nephropathy, DXT, fatigue plus A/N/V plus sallow skin. Investigations: urine dipstick test, first morning specimen, glucose, blood, protein. 24-hour urine protein microculture of urine, kidney function test, plasma urea, plasma creatinine, creatinine clearance, more precise, eGFR, new standard. Electrolytes, ACR guidelines, normal albuminemia M, 2.5 mg/mol F, 3.5 mg/mol. Microalbuminemia M, 2.5 25 mg/mol F, 3.5 35 mg/mol. Macroalbuminemia M, greater than 25 mg/mol F, greater than 35 mg/mol. Management. BP control: no added salt in the diet. ACEI and ARBs should not be used together. ACEI is not used in renal artery stenosis. ACEI/ARBs should not be used if creatinine 30% higher than the baseline or K6-mol/L. Loop diuretics effective in larger doses. Non-DHPCCB beta blockers, lowest tolerable dose of antihypertensive. Emergencies. I. Acute urinary retention of 600 ml urine common in elderly, senile or dementia. Common causes: enlarged prostate, prostatitis, bladder neck obstruction, fecal loading, pelvic mass. Anticholinergic drugs precipitated by extreme cold, excess of alcohol. Neurogenic causes: multiple sclerosis, spinal injury, diabetes. Physical exam: DRE, empty the rectum of impacted fecal material. Neurological exam of limbs and perianal area, if, plus, refer. Management: catheteries with 14 francs Foley catheter and drain. Refer to urologist. MCU: antibiotics if drug induced, withdraw drug, leave catheter for 48 hours, then remove. Trial of prazosin or terazosin. Analgesics: ambulate, attempt to void by standing up, hot bath. Check for prostate Ca, renal impairment.